Welcome, friends, to this wonderful initiative by the Indian Arthroscopy Society, IAS Online, which is a teaching program. I'm Dr. Nilesh Kamat, and today I'll be discussing video technique for a single row rotator cuff repair. We are all aware that Curtis et al. In 2002 described a detailed insertional footprint of the rotator cuff, and he had shown that the rotator cuff does not have a point fixation, but the width of the fixation on an average is 16 millimeters. This was further confirmed by Nottage in 2004, where they further went on to say that the tendon thickness varies from anterior to posterior. To the anterior margin, it's around 11.6, mid tendon is around 12.1, and along the posterior margin is around 12.5 millimeters. As far as rotator cuff surgery is concerned, structural failure is the commonest cause of failure in rotator cuff surgery. There are various papers in literature stating the same, which talks about structural failure as the cause for failed rotator cuff surgery. The SCOI repair, or the Southern California Orthopedic Institute repair, which is a single row repair, was popularized by Dr. Steven Snyder, which involves using single row of strong anchors, each loaded with 3 high-strength sutures, equally distributing the tension and avoiding compromising of the tenous circulation. Insertion of the anchor not along the lateral edge, but near the medial edge of the natural rotator cuff footprint at the tent pit angle under the subchondral bone, which is supposed to be the strongest bone, and creating a microfracture on the exposed lateral part of the tuberosity, where the crimson duvet clot or the superclot will emerge to permit permanent blood supply to the healing tendon and restore the entire rotator cuff footprint. This is a diagrammatic representation of the same, and you can see that this is the tear which is present. An anchor has been inserted right at the junction. Multiple sutures in a simple fashion are passed through the rotator cuff, and after the rotator cuff has been tied down to its point of insertion, the exposed lateral tuberosity, you have marrow vents which are created, which allow the formation of a superclot, the so-called crimson duvet, which allows the healing potential of the rotator cuff. What has also been shown by these authors is that even at 4 weeks post-op on serial MRIs, there is neotendon formation at the point of the microfractures, and a period of around 8 to 12 weeks, you have complete restoration of the footprint, including the exposed part. Biopsy evaluation has shown that this tissue, which is there along the exposed part near the marrow vents, is equivalent to your primary rotator cuff insertion. Today, we'll be presenting a case of a 53-year-old housewife with no comorbidities, presented with history of lifting of a bucket of water from a well, resulting in a jerk around 2 months back, and her primary complaints were painful and weak shoulder since 8 weeks. The MRI showed a full thickness rotator cuff tear on her T2 coronal images. Her T1 sagittal images did not show any fatty infiltration, indicating very good muscle quality. Her Gautellier stage was grade 0. And on a sagittal imaging, you can see that the anterior aspect of the rotator cuff footprint shows a full thickness rotator cuff tear. The patient is positioned in a lateral position. So remember, whenever you're doing a shoulder arthroscopy in a lateral position, the orientation of your glenoid is in a flat direction that is parallel to the ground. You start with a diagnostic evaluation, looking at the posterior labrum into the axillary recess. As you come back upwards, you look at the anterior labrum with the insertion of the biceps. At this point of time, along the anterior aspect, you can see fraying of the rotator cuff with involvement of the insertion, which is causing the full thickness rotator cuff tear, which is corroborative with the MRI findings. The rotator interval is then assessed with the insertion of the subscapularis and the medial pulley of the biceps. Once there is satisfactory evaluation of the residual part of the rotator cuff, attention is then drawn back to the rest of the footprint, which shows all the way right posteriorly to the attachment of the infraspinatus, up to the nutrient foramina, which shows that the posterior cuff is intact. In such small tears, we prefer to use a tear-specific portals. That means staying intra-articular, we use a switching stick or a Wessinger rod to pass through the defect, which allows us to debride the defect. You can see that there is significant fraying of the undersurface of the rotator cuff. When you're doing a repair, you would want to take away this degenerate tissue which is frayed away, which allows the insertion to be brought back right exactly to the footprint. The frayed tissue is then cleared, and then the dimensions of the tear are assessed. You can see that the biceps is not involved, and then you move to the subacromial space. We are visualizing from the posterior portal. The same tear-specific portal is through which the radio frequency wand is coming in. What you can see at the superior end of the screen is your undersurface of the acromion. The first thing that we do is we release the coracoacromial ligament from the anterolateral aspect of the acromion. At no point of time would we excise the CA ligament, and we would simply peel it off, which allows for a later attachment of the CA ligament. Once the satisfactory release is present, then you can assess the tear. And now you can see clearly the tear is visualized. The footprint is then exposed. Also, you should be aware that one of the bleeders which is present in the coracoacromial space is the acromial branch of the coracoacromial artery. And this is visualized when you release the CA ligament on the anterior aspect. Under vision, you can coagulate this and then create a posterolateral visualization portal. So here you can see this is the scope in the posterior portal of the posterolateral aspect of the acromion. My needle is coming in, which would be the posterolateral visualization portal, which gives me a complete panoramic view of the rotator cuff tear. Keeping a switching stick in situ, when I move my scope to the posterolateral portal, the tear can be visualized much better with the junction of the articular cartilage and the bone. From the lateral portal, we then clean the footprint so that the junction of the articular cartilage with the tuberosity is visualized. Using a separate percutaneous portal for anchor insertion, we insert the anchor along the medial aspect of the tibial tuberosity, just lateral to the articular cartilage. So the lateral aspect of the tuberosity is still exposed. This is the location of the portal of the leading edge of the acromion, and then you can insert the anchor of your choice on the medial aspect of the rotator cuff. In a sequential manner, the sutures are then retrieved from the lateral portal, and then they are passed through the rotator cuff using an instrument of choice or comfort. For such small tears, I prefer to use the antegrade shuttling device, which allows me to grasp a good amount of tissue, which is a low tension bite, and then the sutures are passed, which are then retrieved through the posterior portal. The same step is repeated for all the three sutures, and in a sequential manner, initially the tiger, followed by the blue, followed by the white sutures are pushed. So now we have all the three passes through the rotator cuff. Each suture is then retrieved through the lateral portal, and its corresponding partner is retrieved from the anchor, and simple knots are thrown. My choice of knot is a modified Duncan loop, but any choice can be used. And then the rotator cuff edge is reduced to the footprint. The same step is repeated for the other counterparts as well, and all the three sutures are then tied down to the rotator cuff insertion. But what this creates is that an exposed part of the lateral side is present. Although the rotator cuff is brought down firmly onto the footprint, the challenge here is that how do we restore the lateral part? You can visualize that it's a low tension repair without bringing too much of tension onto the rotator cuff. You can see the elastic recoil of the muscle as well. Then attention is brought onto the lateral aspect of the footprint, and using an awl which is around 2 millimeter in diameter, multiple puncture holes are made along the lateral aspect of the foot. These puncture holes release the marrow contents, which can be seen in the form of fat globules. And once the irrigation is stopped, you can see that this goes on to recreate what is known as the crimson buoy. Also, you will realize that the rotator cuff is still repaired, but we are worried about further impingement, which can then lead to a repeat tear. Assessing or reorienting ourselves to the anterolateral aspect of the acromion, you can see that this is a prominent portion of the anterolateral aspect. Coming in from the lateral aspect, using an acrominizer burr, you can flatten out the acromion. Proponents of acromioplasty always recommend only the anterolateral aspect of the acromion to be flattened out, and should be done in a sequential manner to make it coplanar to the rest of the acromion. The other advantage which is present with an acromioplasty is that because of the raw bleeding edge, it allows marrow contents to come from the superior aspect of the repair as well, where papers have shown that this also enhances the healing potential of the rotator. One should know the width of either your RF wand or your acromion burr, which allows you to assess how much of clearance is done to prevent any further impingement. So here you can see that nearly 3 widths of the RF wand or 2 widths of the acromial burr is good enough space to prevent impingement. The CA ligament eventually then falls back in its position and reattaches itself to the anterolateral aspect of that. It's important to go intra-articular to assess your repair. And here you can clearly see that the same portion which was torn, this is the leading edge of the rotator cuff, and the entire rotator cuff has been brought back without any exposure of the tuberosity. So there is no inadvertent pasta lesion, which is a big concern for proponents of double row who say that using a single row results in a pasta lesion. From rehabilitation perspective, the principles are you protect the repair for 4 to 6 weeks, you regain your motion in 7 to 16 weeks, and regain strength from 16 to 24 weeks. These are the general principles followed, but you need to optimize your approach depending on the tear, depending on the patient, and depending on the functional demands. Thank you for your patient listening.